Good evening, everyone. We're just going to give everybody a moment or two to log on, and we'll begin shortly. Right. Good evening, everyone. Thank you so much for joining us today for What You Should Know About Bladder Cancer with our speaker, Dr. Juan Garisto. He is the Director of Urologic Oncology at New York Presbyterian, Brooklyn Methodist Hospital, and an Assistant Professor of Clinical Urology at Weill Cornell Medicine. We encourage you to submit your questions in the Q&A section. Tonight's session will be recorded and sent to all those who registered, and it is my pleasure to turn things over to Dr. Garisto. Thank you so much for being here with us tonight.
Hi, good evening, everyone. It's a pleasure for me today have a talk in bladder cancer. And then definitely this is, for me, it's a passion. Bladder cancer is, for me, one of the best topics and then one of the most interesting management for this disease. So today we're going to be talking about what should we know about bladder cancer. So I'm going to start with the basics, okay? So this is the genitourinary system. What is the genitourinary system? It's basically, a network of anatomical and physiological components that, as you can see, they are composed by, different structures like the kidneys, the ureters, the bladder, and then the prostate. So as you can know, the kidneys are like the filter of the body. And then mostly, the whole blood for the whole body pass through the kidneys. What they do is they filter the blood and the toxins. They produce the urine. The urine goes through the ureters, and eventually, they go to the bladder, which is a reservoir of mostly urine. So this is the bladder. The bladder, the urinary bladder is a hollow, a muscular organ in the pelvis that stores urine, expanding as it fills and contracts to expel through the urethra. And then the shape is usually like a balloon-shaped organ. And then, as I mentioned before, it's located on the pelvis, and then mostly, between the hip bones. When it's empty, the size of the bladder is around 2 inches, but it can stretch around 6 inches when it is full. The capacity mostly is around 4 to 500 milliliters, which is about usually around 1.5 or 2 cups of urine. And that's the organ that we're going to be basically talking today. So mostly, what is bladder cancer? So as you can see, that's the bladder. The bladder is composed with urothelial lining inside. And then when these urothelial linings or the cells or these urothelial linings, they are not, behaving in the proper way, they grow in the abnormal way, they eventually, produce the bladder cancer. So the most common type of cancer is the one that we call urothelial carcinoma. And then this is the one that appears in around 90% of the cases. And as I mentioned before, all inside the bladder is recovered by the transitional cells. And then the second most common type of cancer is rare, but we call it adenocarcinoma. And then the origin is in the glandular cells that are also in the bladder. And then usually there are risk factors. Risk factors is a chronic inflammation, patient who had basically urinary obstructions, or patient who had basically an infection for, we call it schistosomiasis. It's a parasitic infection on the water. And lastly, is the other type of cancer that is also not so common, but also can appear is basically the squamous cell carcinoma. And mostly this is created by irritation and inflammation of the cells in the urothelial lining. Risk factors usually on those patients who had chronic urinary tract infections, for example, neuropathic bladders, they have chronic Foley catheters, or they have bladder stones previously. And then they also have some patients who have a previous history of radiation therapy. Usually those patients who have, prostate cancer, they have radiation, and then one of the most common type of association is with the squamous cell carcinoma of the bladder. So when we treat bladder cancer, this is basically a multidisciplinary care team. There is always, a urologist that, we have urologists and specializes in cancer. This is in my case, I'm a uro-oncologist. There is also, radiation oncology radiation oncology doctors. There is also medical oncology doctors, and there are also other professional health. So what is the role of the uro-oncologist? The role of uro-oncology is basically managing and then, giving, the correct type of treatment in case that, if the patient needs a scraping on the bladder, we call it TURBT, and then, I will explain that after. The type of treatment that the patient will require in terms of, adjuvant treatment or any kind of intravesical treatment, we order it. And then eventually, we also, perform what we call cystectomies, which is basically removal of the bladder if the patient needed. Yeah, radiation oncologists also, work with us very close in case, and then I will explain it after, in case that the patient, is a candidate for something that we call three-modal therapy. And then also the medical oncologists play an extremely important role in the systemic therapy in case that the patient with bladder cancer has unfortunately metastatic disease, or they require any kind of neoadjuvant chemotherapy or chemotherapy before or after the major surgery like a cystectomy. And then I also put, some other healthcare professional because, I here in the New York Presbyterian Hospital, I work all the time very close with the pharmacy team, and then also the ostomy nurses, and then social workers and then physical therapy after any kind of major operation that we perform in patients who have bladder cancer. So I am going to, talk a little bit about basically statistics, and then the statistics in terms of mostly bladder cancers by itself. So these are cancer statistics that were published back this year in 2025. Each year, the American Cancer Society estimates the number of new cancer cases and deaths in the United States, and then compiles the most recent data on population-based cancer occurrence using the incidence data collected by Cancer Central Registry and also the mortality data by the NIH. In this year, in 2025, there's going to be around 2 million new cancer cases and 600,000 cancer, unfortunately, deaths, are projected to occur. And then the cancer mortality rate had been decreasing through the time from the 1990s until today, then 2025, averting nearly 4.5 million deaths since 1991 because reduction in some risk factors like reduction in smoking, early detection on some cancer, and then improvement of treatment options in the setting of patients who had metastatic disease or spread of the disease. So this is our cancer statistics basically for, in this table number 1, present the estimated number of new invasive cancer cases in the United States in 2025 by sex and cancer type. And as you can see, I highlight in the bottom, in the urinary system, we are projected to have, in both sexes, around 170,000 cancers in the urinary system. And specifically, for bladder cancer, unfortunately, we're expected to have around 80,000 of those. You can see in males around 60,000 and females around 20,000. And then, unfortunately, the estimated deaths, around 17,000 and 12,000. So specifically for where are we right now in New York? In New York, for urinary bladder, we're expected to have around 5,000 cases this year in 2020 and 2025. And then specifically, in this figure, I wanted to bring it because it depicts the most common type of cancer diagnosis in men and women in 2025. As you can see, we have prostate cancer, lung cancer, and colorectal cancer, and then You can see the estimated new cases in urinary bladder, are around 6%, and then the estimated deaths, unfortunately for urinary bladder, around 4% or 12,000 males in this area. And then this also, I wanted to bring this because, as you can see, there are different, different type of localizations of the bladder cancer. If, for example, and this is basically a distribution for selected cancers by race in the United States, but eventually can tell what is the prognosis on those patients who had bladder cancer. For example, if we have a cancer that is localized, the projection at 5 years, if for all races, is that this patient, have an overall survival around 70%. If the patient have regional disease or, pelvic disease, where some lymphadenopathy, unfortunately, the overall survival, decreased to 40%. And unfortunately, if the patient have basically distant disease or metastatic disease, at 5 years, the overall survival is 9% on those patients. So what are the main causes of bladder cancer? Every single patient I see in the clinic, I ask about the risk factors. The most common one is the one I'm highlighting on the right, is smoking. However, there are other type of risk factors. For example, cyclophosphamide is this is a type of treatment that patients, female patients, use for the medical oncologist use it for ovaries, breast, or blood and lymph node systems, and then unfortunately the cyclophosphamide, can cause, some bladder cancer after exposure of this medication. Also, radiation to the pelvis. There are several studies showing that, patients who had prostate cancer or received previously some degree of radiation therapy, they have around 2 or 3% of the possibility of developing, another type of cancer secondary to radiation. And the most common one that I did mention before is the squamous cell carcinoma of the bladder. Also, there are some exposures that we had been talking before, exposure to chemicals, interesting the plastics, paints, leathers, and rubber. And then we also spoke before about, parasitic infections. And then one of those is that this schistosomiasis, which is, that is mostly related with, in 1 or 2% of the cases, developing, adenocarcinoma of the bladder. Usually, this type of cancer is a most common type of malignancy in populations in the Middle East and in some parts of Africa, where the schistosomiasis is a widespread problem. Mostly, what are the symptoms? What are the symptoms? So every single patient that comes, I would say that 90% of the patients that comes to me, they are referred basically because they have blood in the urine. And then this is mostly one of the first symptoms. Other symptoms that appear, I would say in 10 to 15% of the cases is usually patients who had frequent and urgent need to pass some urine, some pain, some pelvic pain, some, minimal back pain, but mostly, patient who had blood in the urine. This is the most common sign of bladder cancer. And then this is the main thing that makes the patient basically to go to the primary physician or directly to the urologist. So what do we do? What do we do when that happens, So mostly, I said to the patient, there are 3 things that we need to do when the patient have blood in the urine. First of all, we need to do the famous CT scan. And then basically the CT scan is a special CT scan that is a CT urogram, which basically highlight from the kidneys all the way down to the ureters. And then mostly, also we can see some parts of the bladder. That's the number 1 thing. The second thing that typically we need to do is basically do the famous cystoscopy. And I put a picture on the right, A cystoscopy is a procedure that, we can do in the office and assess the lower urinary tract. So you usually assess for the tip of the penis in males or the urethra in females. And then we go, navigating with a small camera. And then that camera, goes to the bladder, and then we can take a look in the deepest way, what are the causes of hematuria, or if the patient have, any kind of disease inside the bladder, but at the same time, it can have a bladder cancer. And then, yes, it's a procedure that takes me, probably in the office around 30 seconds to 1 minute. Most of the patient ask me like, wow, sure, it does have pain. Well, I would say no, but it creates some degree of discomfort. And then it's a very, very quick procedure that we can basically assess if the patient have a bladder cancer. and then that we need to assess, the locations, the sizes, and then in mostly, the characteristics of that. And the third thing that we need to do is that mostly when we do the cystoscopy, we also take something called urine cytology, which is a urine sample that we send it to the cytologist in the lab, and then where they can assess, under the microscope, if there's some degree of cancer cells that are suggestive for bladder cancer. So those are the three things that typically, are the main things that we perform when the patient have a hematuria. And then, in addition to that, the part of the workup for bladder cancer. No, in the moment that, we diagnose that the patient have a bladder mass, in addition to that, most of the time I complement that type of basically studies, most of the time with a CT of the chest to determine if there is any kind of spread of the disease outside of the bladder. So the next thing, I'm going to run this video, and then, this video basically comes, and then I just wanted to show you because what happened when we have a small bladder tumor. So patient have blood in the urine, we do the history and the physical examination, we are assessed for risk factors, we send the CT scan, we perform the cystoscopy in the office, we see that the patient have a bladder tumor, and then after that we need to consult the patient to get mainly tissue to determine different things on the tissue. First, what is the grade, and then what is the first, I said to all the times to patients, to the first and the last name. So how we do that? And then I'm going to run this video very quick. And this is basically a procedure, we call it TURBT, and it stands for transurethral resection of a bladder tumor. And as you can see on the screen, basically I have a loop that will help me to basically take the tissue that I will send to the doctors, the pathology, that it will help me to determine at this point what is the first and the last name of this bladder mass. Most of the time, is urothelial carcinoma, as I mentioned before. However, this is a procedure that we perform, and it's an outpatient procedure the majority of the time. And then after the procedure, that takes around, depending on the size of the mass, around 30 to 45 minutes, we're able to basically remove mostly the tumor and then send it to the pathologist. Sometimes, we leave a Foley catheter. Sometimes we do not need to leave a Foley catheter. Sometimes the patient, I would say that 95% of the chances the patient go home the same day, and 5% of the chances the patient will need to stay in the hospital. And then I would say that depending also on the location and the size and the characteristics of the mass, mostly, these patients in 80 to 85% of the cases, they won't need a Foley catheter, and then around 10 to 15%, they will need a Foley catheter. After that, they will remove it a couple of days after the procedure. So why we do this is, the most important thing is to take the pathology and send it, the tissue, and send it to the pathologist to determine a couple of things. What are the things that we need to determine? I always explain to the patients in the simple way. We need to determine first, what is the first name? As I mentioned before, the most common type of cancer, we call it urothelial carcinoma in 90% of the cases. And the second thing that we need to determine is basically the characteristic. We call it the grades, okay? And then in a simple way, there is something that we call low grade, and then also there's something that we call it the high grade. For the low grades, I always call it the cats, and the high grades are the tigers. It's important to note to remember to advise to this patient that, if you have a big bladder mass, for example, or you have a mass that have bad characteristics, most of the time the guidelines refer that if the patient have a high grade or a tiger, or is basically circumscribed to the first layer of the bladder, I advise to the patients to remember that 20 to 25% of the patients, they will require a second scraping of the bladder I would do it around 2 or 3 weeks after that. Or if for whatever reason the tiger have, or the high grade have basically a stripe, a different variation, histological variation, which is a little bit more aggressive, then that patient will require, a second scraping a couple weeks after to get more information about the characteristics of that basically cancer. And then let me divide this conversation in two now, because, I put the picture on the left. As you can see, the picture on the left has these little things. We call it TA, T1, T2, T3, and T3B. So let me put it in the very simple way. So from inside to outside, This is the first layer of the bladder, so we call it the urothelial lining. The second layer of the bladder is the muscle, and the third layer of the bladder, is the fat. Okay, so if you have disease on the first layer of the bladder, then we call it non-muscle invasive bladder cancer, and then basically the cancer that grows only in the first layer. Okay, and then if it's in the second layer or the third layer of the bladder, we call it muscle invasive bladder cancer. And then this is the type of cancer that eventually is in the muscle or in the fat. And then the reason I'm telling you that is because based on this, we can manage in a better way the type of cancer. The management is completely different for a patient who had non-muscle invasive bladder cancer, which is a superficial type of cancer, versus the patient who had basically a muscle invasive bladder cancer, which is in the second or the third layer of that. And that's why it's important, this division. And then this is the guidelines, the National Cancer Comprehensive Guidelines. I just wanted to bring you this about the workup that we do before as a primary evaluation for those patients. And then, as you can see, we divide this in non-muscle invasive and then muscle invasive bladder cancer. So non-muscle invasive bladder cancer. Let's talk, and divide this conversation in two. Now we're going to talk about the superficial ones, or type of bladder cancers. So once we take the pathology report, we stratify those patients that depending the characteristics. If it's basically a cat or it's a tiger, if it's in the first layer, or basically the tiger have a stripe. Why? Because depending on those characteristics, basically is going to be the type of surveillance cystoscopy that the patient is going to have, or it will be basically the type of treatment that potentially the patient will require down the road. Let me put it like this: when the patient have a low risk, and I will put it in the next in a simple way in the next slide, probably over here. So if the patient have first a scraping on the bladder and then it shows low risk, let me put it in the simple way. Typically that is a patient that, is mostly cured by the simple scraping. And potentially that patient will need to have just a surveillance cystoscopy, and typically we will do it at 3 months and then 12 months after the scraping on the bladder. And then after that, we surveil that patient basically every year for a period of time of 5 years. In the other side, if the patient, for whatever reason, if have other characteristics, or if a real tiger with different stripes, so the management is going to be completely different. And most of the time, this is a type of patient that will require an additional type of immunotherapy that I will talk in the next slide. And then the difference is that most of the time, this is a patient that potentially will need to have a very stringent follow-up with cystoscopies or taking a look inside the bladder in the next 3 years to make sure that the patient do not have any kind of relapse of the cancer. And then the second difference is that most of the time the patient who had basically intermediate risk, or a more less aggressive type of cancer, we will need to put some medication that we call it BCG for a period of time of 1 year. However, for the patient who have a high-risk bladder cancer, which is a little bit more aggressive, and then have another characteristics more aggressive, most of the time this patient will need to have a maintenance, or a BCG treatment for a period of time of 3 years. And in that period of time, we need to assess if the cancer come back. So what is the type of thing that we use? Is historically for around 40 years old, basically in Canada, in the University of McMaster, there was a doctor, his name was Alvaro Morales, who basically discovered the utilization of BCG. And BCG is a type of immunotherapy that is a treatment that boosts the ability of your immune system to fight against the cancer. And then BCG stands for Bacillus of Calmette-Guerin, and then this is an attenuated mycobacteria, which is the bacteria of the tuberculosis, but it's not active. So then, when this medication is instillated inside the bladder, so your body will react against that type of the cells, and then will overkill the cancer cells that are surrounding inside the urothelial line. This is a type of treatment that I basically we perform it over here, and then mostly we typically give it after the first scraping or the second scraping, and we have the first name and the last name of that type of cancer. And then eventually, that patient will need to have a healing on the bladder, and then we usually instillate around 4 to 6 weeks after we finish the last TURBT on him, in order to make sure that it doesn't have any absorption of the drug inside the organism. How we do this? Basically, 4 to 6 weeks after the scraping on the bladder, the patient, we assess it with a urine sample to make sure that the patient do not have any kind of urinary tract infection. And second thing, we start instillating a full dose of this medication. We place it, through a Foley catheter, which is a catheter is coming, through the urethra of the patient, and then we basically instillate it inside the bladder. It stay there for around 1 to 2 hours, and then after that, the patient basically urinate the medication with a mix with the urine. This is a medication that needs to be received for a period of time of consecutively for 6 weeks. And in that period of time, the patient needs to go, to the cancer center in order to receive the instillation. That's number one. Then, when he finished that installation, based on protocols, the patient needs to wait a period of time of 3 months after that. And then in order to perform that cystoscopy and then make sure that there is no relapse for the bladder cancer inside. That's number one. And number two, it's important to notice that, if at that moment, after one of the side effects that the patient can have, after installation of the BCG, is basically patient can have a little bit of burning sensation, pain, urgency, and then, it's very rare, but if there is any absorption of the drug, that potentially is extremely rare, but the patient can develop, symptoms of tuberculosis down the road. There are other type of medication that I will explain, in the next slides, because it depends mostly, in the type of management or if the cancer come back down the road. So what happened, if at 3 months the patient come back, for example, and then at some point the patient, we do the cystoscopy and then the patient still has a tumor inside. So yeah, we will need to go, in a second time to scrape, again, perform another TURBT. And at some point, I will advise to the patient to have, reinduction type of BCG treatment to basically consolidate that patient and make sure that, after a first response, if he doesn't respond the second time, we have another type of drugs in order to preserve the bladder at this point. So usually BCG, based on the statistics, usually when the patient receive an induction BCG, the average of response of those patients is around 60 to 70%. For every 10 patients, that they receive BCG, around 6 or 7 will have a response and the cancer won't come back, and they will basically keep the maintenance for a period of time of a year or 3 years. Or in the other case, in around 2 or 3 of those patients, the cancer will relapse, and at some point we'll need to do basically a second scraping. I'm sorry. What happened, if at some point, this patient is still having a persistent bladder cancer despite the medications. So every time that this happens, I need to speak with the patient very, very clear and then offer them, unfortunately, the cystectomy, which is removal of the bladder. Why? Because what we're trying to prevent at this point is that the cancer go from the first layer to the second layer, which will decrease at some point the survival rate if it goes to the second or the third layer, or if it's spread outside of the bladder. However, what happens if the patient do not want that? In the past probably 5 years, there has been a whole revolution about any other drugs that have been appearing, combinations or new drugs. And then this is a slide that I come, in to assess, what happened if the patient do not have a response to the BCG. So, well, there is a combination that we also offer here in the New York Presbyterian Hospital, gemcitabine docetaxel, which is a combination of two medications, and the other one is, I have been applying it here. is nadofaragine, which is a medication, is basically a non-replicating virus that we use as a vector. We insulate it inside the bladder, and then usually at 3 months, the complete response is around 50%. There's another one is a combination of NAA and BCG, which is is a special type of what we call it response factor. We call it interleukin 15, and then it's also instillated inside the bladder. And then, back in 2020, the whole revolution appears about the pembrolizumab. This is basically a type of immunotherapy that is injected, and then is injected. And yes, the rate of response is around 40% at 3 months. However, we need to have this discussion with the patient to make sure that the patient understands at some point that eventually the cancer can come back, and then we will need to offer a cystectomy. So how we follow this patient who had high-risk bladder cancer? Yes, with cystoscopy every 3 months, we need to do CT scans, and then these patients will eventually need to have, if the patient is good and then responds to the BCG, and then there is no relapse of any kind of cancer, then he will need to have a maintenance type of treatment that will be around 3, 6, 12, 18 months, and 24 months after they have the first scraping, and then waiting that the cancer do not come back. And this is basically the maintenance therapy that then they will need to have. So in a nutshell, how we treat non-muscle invasive bladder cancer, the superficial type of cancer. So yes, if it's low grade, we just, scrape it and it's done, okay? And then typically we need to do some surveillance cystoscopy to make sure that the cancer no come back. So if it's, if the type of cancer, the urothelial cancer, unfortunately have some stripes and it's a tiger, yes, the preferred type of treatment is BCG. And then eventually, if the BCG do not have, or the patient have a relapse, yes, we need to offer him, removal of the bladder. And eventually, there are another type of treatment that, we had been offering to the patient, not with 100% of guarantee. However, these are the ones that I mentioned before. Next slide. What happened that unfortunately the patient had basically cancer on the second or the third layer of the bladder. So we call it muscle invasive bladder cancer. So the treatment is typically, this patient will have a consult with the medical oncologist and with me, and then which is the urologist. And then, the medical oncologist will offer them, typically neoadjuvant chemotherapy, which have, as outcomes or survival rates improvement around 5%. In addition to that, when they finish the chemotherapy, usually they will offer, the cystectomy, which is removal of the bladder. This is a procedure that, surgically for me is one of my favorite procedures. However, it's a very morbid procedure. Yes, you have around, based on the statistics, around 25-30% rate of complication. Patients have 30% of readmission, and I have a whole conversation with them about what to expect before, during, and after that procedure. In terms of a quality of life, and then in terms of type of urinary diversion that we need to offer them. Yes, this procedure is performed robotically. I perform it robotically or open, and then it doesn't matter the type of approach. It matters you basically remove the bladder who had the disease inside. Yes, what happened when we remove the bladder? So where is the urine going? The urine cannot go directly, to the belly. It's not possible because, the toxins, will be reabsorbed by the body. So we need to create something we call a urinary diversion. And then I'm going to be very simple here. The most common type of urinary diversion we offer is what we call ileal conduit. There's also, pouches, and then neobladder. And then what is that? We take a piece of bowel, and then from that piece of bowel, basically we create the reconstruction, and I will show it in the next slide. So mainly, I'm not going to go into much detail because this is basically, there are two types of mainly urinary diversions, and then I will keep it simple, very simple. Neobladders are the one that basically we create, and then with a piece of bowel, and then the patient urinate, and then we inside the body, and they do not have a bag. That's pretty much. And the other one, the most common one, is a non-continent ileal conduct, which is a type of heterotopic urinary diversion. Again, this is the one that basically the patient do not have a bag. It have some criteria, and then we call it, in the surgical field, the Studer neobladder. And then, as you can see, we create a reservoir inside, and then we attach it basically to the urethra of the person, and then have some advantage of disadvantage. There's some criteria specifically to offer to a patient a neobladder, so which is the neobladder that we're creating, and it's inside the body. And then it have also advantage and disadvantage. Not every single patient we can offer this type of surgery or reconstruction after that. And yes, it have some contraindications. If the patient have chronic kidney disease, we cannot do this because there is going to be a whole absorption of the urine by the piece of bowel that we create. The patient also can have some urinary incontinence, and then they will need to create some they will need to catheterize some of the times. And the other one is the most common one, that in 80% of the chances we call iliac conduit, is basically a piece of bowel of around 10 to 15 centimeters, and then that is basically close to the major the ascending colon, and then from there we take this piece of bowel, and then mostly we create the bag that is going to be attached to the patient. I bring this is because this is basically the urostomy. And then this is the whole reconstruction inside. The ureters are attached mainly inside the body to the piece of bowel. And this is basically the piece of bowel that is coming all the way. Then the patient is going to be urinating through a bag. Finally, I just wanted to bring into attention, the management in a nutshell of patient who had basically muscle invasive bladder cancer. So if the cancer is in the second or the third layer, and then in those cases, basically, if the patient is eligible to have a major operation that we call cystectomy, when we offer them a consult with the medical oncology, where they give in, typically a type of chemotherapy. Follow it after that 2 or 3 weeks when they finish the chemotherapy with a cystectomy, which is removal of the bladder. Some of those patients, after that, depending on the pathology report of the whole specimen of the bladder, some of them will require some additional type of immunotherapy of chemotherapy if the mass or the bladder had bad characteristics. And then what happens if the patient is not eligible to have a major operation that is basically changing the life? We call it cystectomy ineligible. Yes, there are other variants that we can offer, and then I'm going to talk very briefly about trimodal therapy that had been, probably, in the research in the community, in the urology community, for probably the past 10 years, 15 years. However, there have been some major advance in recently. So how we monitor those patients after, they have a removal of the bladder? Yes, depending on the pathological report, these patients will need to have at the same time some CT scan, some to make sure that they don't have any complications secondary to the urinary diversion. There are also going to be some metabolic change inside secondary to the absorption of the urine inside the piece of bowel, and that's why they need some blood work. And then finally, yes, if the patient, depending on the final pathology, will have some good survival rates in the second or second layer of the bladder. Finally, I wanted to talk about a little bit about this recently, back in 2023. There is this comparative study for one of my professors, Dr. Alexander Slora. What is three-modal therapy? For example, the patient he have a poor performance status. He cannot go for a major operation. So, well, three-modal therapy is, as I said, three. We perform basically a maximal TURBT. Basically we scrape the tumor as much as possible. And in addition to that, I usually inject a marker inside the bladder, and then in order to help the radiation oncologist to basically, give to that patient radiation therapy to the side of the bladder that they do have the disease. And then in addition to that, the patient at the same time concurrently is receiving a chemotherapy. That's why it's a multidisciplinary team between the medical oncologist, the surgical oncologist, the urologist, uro-oncologist, and then also, the radiation oncology. There are some indications. Not every single patient is candidate for this, and then usually, we leave it for patient, and I have given it before for patient who had small solitary tumors that are T2 or T3, and then good bladder function. It doesn't need to be any superficial type of carcinoma. We call it carcinoma in situ. Unfortunately, this, after that, the patient need to understand that there's going to be an stringent follow-up to rule out any relapse after the bladder preservation treatment. And then, if there is something that, the cancer come back, usually, based on the statistic and based on this paper, mostly these patients will have 20% of relapse of in the superficial layers of the bladder with a non-muscle invasive bladder cancer. And then typically they will need to be treated with, as a non-muscle invasive bladder cancer, it will be with TURBTs, and then followed by eventually, BCG if it's needed. And then what happened if, despite the radiation and the chemotherapy, the patients still have muscle invasive bladder cancer? Then, in 13% of the patients will require a salvage cystectomy, which is salvage mean that we remove the bladder over basically radiated tissue, which is a little bit more basically the patient have a little bit more risk of complications. And for those patients, I typically not offer any neobladder, because radiated tissue is the healing process is going to be extremely slow on that patient. Finally, I just wanted to bring this basically in a nutshell, how we treat advanced metastatic bladder cancer. Yes, what advanced metastatic cancer, it means that, well, what happens if the patient have disease in different part of the body? It's not just localized, and unfortunately. Recently, last year, it appears, in a very reputable journal, basically a study that, it had been revolutionizing, and then we give it here also in the New York Presbyterian Hospital, the combination of vedotin and pembrolizumab, and then it had been giving very good survival rates on those patients. Typically, when those patients did have, metastatic disease, that the type of chemotherapy that we used to offer to them is a combination of cisplatin and then gemcitabine. However, there's some toxicity that the patient can develop in that period of time, mostly because the majority of these patients have we're treating basically elderly population on bladder cancer, but at the same time they have some degree of renal impairment. And then cisplatin is nephrotoxin, and we cannot give it, in to every single patient. So, it had been a game changer, the vedotin pembrolizumab, on those patients who had advanced of metastatic type of bladder cancer, and then improving the survival rates on those patients. Thank you. And then, any questions that you guys have, happy to answer.
Yes, we do have quite a few questions. First of all, thank you so much. That was so helpful and so informative. One of the questions that we received is, what happens if you get a reoccurrence of high-grade non-invasive bladder cancer after the induction phase?
So that's an excellent question. As I mentioned before, when you have the first scraping, and then I'm going to put it here, and put it the slide of the, let me see, of the slides of the BCG treatment. What happened when the patient do not respond to the BCG? So usually, after the first scraping, the response is going to be around 60 to 70% of the BCG. If that doesn't happen, and then the first cystoscopy does show that the patient have a relapse, we need to offer them a second TURBT, and then scraping the bladder. If the pathology, the first TURBT and the second TURBT shows the same T1 high grade urothelial carcinoma, then on those patients, typically I offer to them, that there are two answers right now. The first answer is that yes, but we need to we need to offer them radical cystectomy, which is removal of the bladder. However, I also offer, a second reinduction of BCG. So 4 to 6 weeks after the second TURBT that they have, basically I offer another round of induction BCG. If at that time the patient, we 3 months after, despite that, they do still have, some relapse of the cancer, then, we need to basically offer them mostly, cystectomy, versus, we enter in the paradigm or BCG refractory bladder cancer, which is a cancer that is refractory for a type of treatment. And then these are the options that I mentioned before. Options like the most common one that we're using right now is gemcitabine docetaxel. We also, I offer to them with a medical oncology, in conversation with them, the pembrolizumab IV. And then the last one that I have been using as a last resources is most of the time the nadofaragine, which is the the one that the FDA was recently approved around 1.5 year ago. A little bit expensive, however, have a rate of response around 50%. If every single time that we repeat the cystoscopy and then we still have a relapse, my obligation as a surgeon is have a thorough conversation, a real conversation with the patient, and then tell them you need a cystectomy versus keep trying with another type of intravesical chemotherapy in order to try to preserve the bladder as much as possible.
Perfect. Thank you. And then someone else is asking, what is the difference between endometrial cancer and bladder cancer?
So endometrial cancer is one thing. It's basically a gynecological. This is for women's. Let me put it like this: the bladder and the endometrium, these are two organs, and then both of them are neighbors. Okay, so the endometrium, and then I work all the time with the gynecology oncology here in the Brooklyn Methodist, and then all the time they call me. Why? Because the endometrium is next to the bladder. And every time that they basically are basically doing a hysterectomy, which is removal of the endometrium, mainly they usually call me in order to deattach the bladder, or mostly put some stents to make sure where are the ureters coming from the bladder. So there are two different type of cancers. One is for the urinary system, which is the bladder cancer, and then the endometrium is for women's, and then it's the neighbor of the bladder.
And then someone else is saying about urethral cancer, that they were diagnosed in 2003 because they had discomfort, and their urologist listened to them and decided to do a biopsy, but that they didn't have any obvious symptoms. So I guess the question is, what are some symptoms that women specifically should be looking out for?
I would say that in women specifically, I have treated a couple of urethral cancer. Urethral cancer. What is a urethra? Okay, the urethra is basically the conduit that is coming from the bladder to the outside. Okay, so in the men's, the urethra usually have a length of around 10 to 12 centimeters. Is basically the pipe that is going inside the penis. In the women's, basically the urethra goes directly outside, and then usually the size is around 2 or 3 centimeters in size. So usually women's, the majority of the time that I have seen those patients is that it's a rare cancer, first of all. However, they usually have obstruction, they cannot urinate, and they have usually, recurrent urinary tract infections, and I can even have some blood in the urine. But the majority of the time, the first thing is that they cannot urinate because the mass or the growth of the cancer go inside the lumen, and then it obstruct the pipe that is going from the bladder outside, and so they have some difficulty for urinating.
Okay, perfect. And then someone else is saying if they have high-grade TCC with rapid reoccurrence after TURBTS, still outside of the muscle layer, is a
Yes,
sorry,
radical cystectomy.
radical cystectomy still the safest choice for 10-year survival?
I would say yes. I mean, these are specific, cases. However, every time that I see a patient that, have a recurrence, a relapse, and the BCG is not working, and then we're using 1, 2, 3 different agents, intravesical agents to looking forward to preserve the bladder. Eventually, this is a patient that every single time that, I offer an intravesical type of treatment, I need to be, concise. Yes, the best treatment, in order to prevent the progression from the first layer to the second layer is radical cystectomy, which means removal of the bladder. Unfortunately, this is the case.
Someone else is asking, are there other ways to assess the outlook without a cystoscope?
Yeah, unfortunately, no. Yeah, the cystoscopy, for us is basically the best type of way to assess the bladder. It cannot be replaced. There have been some new trends of the utilization of urine biomarkers. However, in order to detect some bladder cancer cells, however, it's not 100% accurate. That's number one. And number two, yes, we need to see, with a cystoscopy and assess inside the bladder to determine, the characteristics of that mass, the position in relation to the urethral orifice, or how many of these masses are inside. So, unfortunately, no.
So someone else is saying that they had a cystoscopy, and it was negative with no tumor. However, their MRI is still showing something suspicious. Um, how accurate is this test?
Yeah, so that's a good question. So MRI, had been in the, a new trend in the past probably, I would say 5 years from now, and then we had been using more and more and more MRIs to determine basically how the bladder cancer moved to different layers of the bladder. And I use it very frequently, to be honest. And then, yes, when I have a suspicious that there's some muscle involvement on that patient, despite, that the cystoscopy is negative, I typically, offer to those patients basically a more aggressive scraping inside the bladder, because I have had cases before where you have basically in the cystoscopy completely normal, but unfortunately you see like a little small hill inside, and you have the clinical suspicious of some disease that can be inside the bladder in the different layers that we cannot see in the very surface. So I offer to those patients going more deeper, and then the MRI usually help me to basically assess that part and help me to take that decision in order to counsel a better patient, and when I offer that TURBT.
And then someone else is asking, is there any correlation between people with spinal cord injury and having bladder cancer?
The answer is yes. One of the first layer I mentioned before is that patient who had, a neurogenic bladder, or, they have chronic indwelling Foley catheters. Usually they have a more around a little bit more predisposition or risk factors to develop bladder cancer. And I have done a couple of cystectomies in my career, around 4 or 5 of those of patients who had, a Foley catheter for years, and then mainly, they develop bleeding. We do a biopsy, and it shows, the most common one is a squamous cell carcinoma on those patients. Um, and then yes, we offer them, a cystectomy depending on the case scenario that we present.
Mm. I see a few people raising their hands. I just want to let you know, if you can please submit your questions in the Q&A. We're happy to try to get to all of them. Let me just see if there's any other questions here that we missed. And then some people are also asking, is there anything that they can do to reduce their risk of bladder cancer?
Reduce the risk, I would say stop smoking, because the only thing that smoking causes is basically cancer, number one. And number two, as a joke, it gives business to the urologist.
And if they are diagnosed with bladder cancer, do their chances of getting another type of urologic cancer increase?
Well, I would say, let me answer this in two. Most of the time, the patients who have bladder cancer are smoker. And then, yes, those patients who had, smoking, they can have, not just bladder cancer, they can have bladder cancer in the whole urethral lining, including, the kidneys. That's number one. Number two, they also can have, there's a lot of association with lung cancer, and then every other type of cancer. There are some syndromes, that I also have surveilled here in New York. Mostly, there are some susceptibilities of patients who have Lynch syndrome, and this is a syndrome that basically they have upper tract urothelial carcinoma. Sometimes they have, when that type of cancer sit in the bladder, they have also bladder cancer. They also can have some polyps on the colon, and then we need to surveil those patients very often. I usually surveil it with CT scans, and then most of the time urine cytology and cystoscopies down the road when the cancer is cured.
And then someone else is asking, how long do you have to do the maintenance cystoscopies if the results continue to not identify any cancer reoccurrence? Like how many years?
Yeah, that's a good question. So let me divide this conversation in two. Okay. It depending on the the patients. If the patient have basically there are protocols already established for this, first of all. But when we risk stratify the patient, if the patient have a high risk bladder cancer, non-muscle invasive bladder cancer in the first layer, we typically need to surveil those patients based on guidelines for a period of time of 5 years. Number one, and then usually in that period, in the first 2 years, there's going to be a cystoscopy every 3 months. So it's a very stringent follow-up in order to make sure that there is no cancer relapse. And then if the patient once they finish the basically the treatment, the maintenance treatment for high risk is 3 years. Based on that, we keep surveillance for a period of time of 5 years, and then when they reach 5 years, I always have a philosophical discussion with those patients about, yeah, sure, one thing is the book, the guidelines. The guidelines said, the period of time of 5 years of surveillance. However, there are some patients that, they are willing to keep, an eye on the bladder, and then, they can come, in every year or every 2 years, basically, to do a cystoscopy if they want. And that philosophical discussion is, what do you want to do in terms of, sure, you want to keep the follow-up, or basically just follow and stick with the guidelines that suggest just 5 years. If the patient have an intermediate risk bladder cancer, non-muscle invasive bladder cancer, the treatment of BCG, the maintenance is for 1 year. Okay, we give it at 3, 6, and 12 months after the first TURBT, and then as I mentioned before, usually the rate of mostly of killing the cancer is around 60 to 70%.
And then we have time for one more question. Someone else is asking if urethral bladder cancer is something that typically runs in families, and is there a test that they can undergo to detect bladder cancer early?
Yeah, that's a good question. I think that there's some genetic predisposition, and then we do not have properly, a way to screen those patients. However, of those patients who had, family, we try to family history of bladder cancer. We try to tailor it, and then most of the time, we offer them, a cystoscopy, or a urine sample. A urine sample, I'm looking for microscopic hematuria, which is little tiny dots of blood in the urine, in order to make sure if the patient have anything else hiding inside the bladder.
And then we have one more quick question. Someone else is asking if heavy coffee drinking can correlate to any of this.
Well, thank God that no, because I drink coffee all day, all day, and then
We were all listening very intently for that answer.
yes, I think usually around 4 or 5 coffees, to keep, the day as it is. And no, no, there is. I have not read any paper or any article linking coffee or caffeine related. Yes, one of the, as sometimes I see general urology, and in 10% of my practice. And then yes, one of the things that unfortunately, coffee makes you pee more often, and then it creates urinary frequency. But that's pretty much. It's not related with bladder cancer.
Okay, perfect. We're all very happy to hear that.
Yeah,
Well, Dr. Garisto, thank you so much for
it's
your
a
time
pleasure
this
for me.
evening. You were so helpful and so informative. And to all of the attendees who joined us, we really appreciate you spending part of your evening with us. We're so happy to have you. As a reminder, this entire discussion will be emailed to everyone who registered probably early next week. And we absolutely look forward to seeing you for future talks. Have a
Thank you so
wonderful
much. It's
evening,
a pleasure.
everyone. Thank you.
Okay, bye bye. Good evening, everyone.